It's a great pleasure to be here. I would like first to greatly and warmly thank the chairperson and organizer for this kind invitation to give this talk. I hope the slides are coming. Yeah. So the talk is the identification of potential treatment targets in advancing MS. Which I have also to thank about the simplicity of this topic, because of course it's very large. I will try to cover this in a comprehensive way. So here are my disclosure, but they are not really linked to the present talk. So we all know that for MS we benefit for many approved therapies that target the inflammatory process, and that those therapies are really active, but mainly during the relapsing phase. And there is still an unmet need, which is to find therapies that could either prevent or even reverse the disability accrual and worsening. So finding new targets is quite a long road from bench to patient care. And very schematically, there are several steps that we have to reach before having such a therapy. The first one, obviously, is to identify key biological mechanisms that could be identified mainly from models, MS models. The second one, which is a key one, is to demonstrate that these mechanisms are relevant also in humans with MS. And we have many examples of mechanisms or drugs that have been found in rodent models, but they are translated to human study and they do not work. So it's quite classical, and it's a very key step to show that the mechanisms that have been obtained from those models are really relevant in humans with MS, and this can be reached either by investigating post-mortem samples or by doing well-designed pathophysiological clinical studies in vivo. Third key step also would be to discover or generate therapeutical agents. It might be drugs, it might be other strategies. And four, we must select the most promising agent or drug for before doing pivotal trials. So we have to think about some sensitive, innovative phase 2 trial design to select among the possibilities which one would be the most relevant for MS. So in terms of mechanism, I will be very simplistic to overview this topic. We know that probably disability worsening is linked at the end to a neuronal pathology or to neurodegeneration. And this might be linked to energy dysregulation that may conduct to this neurodegeneration. So what are the possible mechanisms that will drive, that will induce this neurodegenerative phenomenon? There are many, probably. This is a complex disease with multiple factors, but very simplistically, we can identify or pick up two main. The one is linked to the myelin dynamics. We know that MS is a demyelinating disease, and probably the remyelination process may be linked to neurodegeneration. And the second one would be the inflammatory process, and especially the persistent neuroinflammatory process in the brain or in meninges. So these two mechanisms are probably the two most advanced to explain disability worsening in MS to date. So I will try to overview whether this mechanism has been investigated and pass through the case steps I just detailed before. What do we know about remyelination? We know now from many years, it's almost 50 years ago, that has been discovered the fact that some remyelination could occur in the adult central nervous system of animal models. This was this pilot work from Bungay and Bungay, also from Perrier and Grégoire, and we know that those remyelinating sheets are characterized by their aspect that they are thinner than the normal myelin sheet, and they are shorter internodes. So they have been identified a long time ago, and there has been a huge work done in those models showing that in experimental models, when remyelination takes place at the right time, it can not only restore a secure axonal conduction, but also provide some neuroaxonal protection. So it's probably one of the best ways to achieve neuroprotection in the CNS. So what are the case steps for lesion to get remyelinated? Here again, huge work in animal models has been performed, and the mechanisms have been well dissected. And we know that this is not the mature oligodendrocyte that has been demyelinated that will provide the remyelination, but it's mostly some cells that belong to the oligodendrocyte precursor cell population that following demyelination will become activated and therefore proliferate, migrate towards the lesions, and therefore differentiate in mature oligodendrocyte before contacting axons and making new myelin sheets. So all these steps have been well dissected at the cellular and molecular level, and we know that a failure of the remyelination process could involve any of these case steps, either a defect in proliferation migration or a defect in differentiation or remyelination itself. So the experimental work have well described the cellular and molecular events involved in the remyelination process. What do we know in humans now? From pathological studies, there have not been so much studies that investigated the remyelination process in humans, but there are some. And remyelination can be identified by this kind of lesion that we call shadow plaque due to the thinner and the shorter myelin internodes. Those plaques that are considered as repaired appear as less colored by the look sulfur blue compared to a normal myelin that you can see. And here you have a plaque which is fully demyelinated. And in this very seminal work from the Lastman group, it has been shown that the shadow plaques in the white matter could be found in humans with MS. So this phenomenon occurs in the MS brain, but it partly fails. And only a subpopulation of patients, you can see here the plaques that are not repaired in red and the ones that are considered as repaired in blue. And it has been shown that only a subset of patients can really fully repair their lesion. There are less than 20% of patients that can really achieve a good remyelination at the postmortem stage. All others have various levels but partly fail. And this has something to do probably with the prognostic of the patient, as patients with a better ability to remyelinate from this study had an older death, so they live longer if they could remyelinate well. So from this post-mortem study, it was shown that remyelination can occur, but it partly failed. And you have also this very large study from the Mayo Clinic group published in Annals of Neurology, which investigated the whole CNS and showed that the remyelination could be seen in many regions of the CNS, but the conclusion was also that in most of the cases, remyelination is not complete, pointing to a global failure of this mechanism, contrasting with what we know from animal models, because in an animal model, when you demyelinate a mouse, it will remyelinate, and even if we demyelinate several times, it will repair very efficiently. So from a pathological investigation, what do we know also about the mechanisms that could be involved in this failure? There are many, as I said, all the steps could be impaired, and we have to keep this in mind. But probably the dominant hypothesis has been this one, that there is a differentiation, a defect in the oligodendrocyte lineage. And this has been mainly driven by the very elegant studies from the Bruce group, showing that even in very chronic lesions of MS at the post-mortem stage, you have still some precursor cells, some oligodendrocyte precursor cells, as you can see here. And some of these cells has been even able to differentiate and to contact axon, as you can see here, but they fail to make myelin. So the dominant hypothesis has been that there is a blockade of terminal differentiation of oligodendrocytes and of myelin sheet formation along the axon. So this is post-mortem study. What do we know in vivo? Because obviously, post-mortem is only the latest stage of the disease, and we did some dynamic study in vivo to really check whether this phenomenon could be relevant, clinically relevant in MS. So we investigated this a few years ago by developing an imaging strategy, which is a positron emission tomography strategy using some tracers that could stain myelin and that could be able to quantify the myelin dynamics, either myelin loss and repair. I will go quite quickly through this, but here are the compounds that we have used. There are repurposed compounds from Alzheimer's research, as we showed that myelin stilbene and benzoyl compounds could both stain, for some of them, myelin, and this has been shown for several compounds. You can see by fluorescence in animal samples that it could very well stain the myelin sheath here in the corpus callosum and many myelinated areas. So we applied this strategy to patients with MS, and we have investigated the cohort of patients with an active relapsing MS. So they had active lesion on their scan, and we first showed that most of the demyelination in the brain of an MS patient occur within the white matter lesion. In the normal appearing white matter, you have not really a demyelinating component. So if you want to look to the demyelination and remyelination process in a sensitive manner, you should mainly look to the white matter lesion. And therefore, we conducted a longitudinal study by developing some processing methodology allowing to classify each voxel in the brain as either demyelinating with time or remyelinating with time. I will not develop all this methodology, but you can see two examples of brains that we have investigated in our cohort. In red, the voxels that are demyelinating with time in lesion, and in blue, the ones that are remyelinating. And you can see that those patients are quite heterogeneous. Some patients are actively demyelinating, but they do not repair, or very few voxels are repairing. Whereas other patients, and these were our champion of the group, also demyelinated with time, but they are able, in parallel, their demyelination to repair with time. And we are able to stratify our cohort of patients. In red, the patient that demyelinate, but with a very poor remyelination, and in blue, the one that also demyelinate, but they are able to repair together with the demyelination process. And we further showed that this was not the demyelination itself that was linked to disability. We have measured the EDSS score, but also the MS severity score. But it was the ability to repair the lesion that was strongly linked to a DSS score. So meaning that probably the ability, the individual potential to repair the lesion may drive some aspect of disability worsening. So this showed really that remyelination in MS in vivo in human patients is indeed relevant in vivo, as each patient presents an individual remyelination potential, which may be critical to determine disability worsening, and therefore it may allow to stratify patients and probably also to evaluate drug in early phase trials. So now, coming back to the third step that should be covered, do we have in hand some compounds, some drugs that could be used now to stimulate this repair process that is failing and that is clinically relevant in patients. So probably you heard about this very elegant work from the team of Jonah Chan. He has developed an assay using this kind of micropillar on which oligodendrocytes are put, and they can make a sum of myelin sheath structure, and he can screen among many drugs which one could enhance oligodendrocyte differentiation and myelin formation. And by screening a huge number of drugs, repurposed drugs mainly, he was able to identify a family of compounds which act through the muscarinic receptor. The most efficient of this compound was the clemastine, you can see here. But you have also some other compounds such as oxybutynin, which we use for bladder symptoms that could also, in this model, induce some effect on the myelin sheath. He further showed in many, many experimental models, either in vitro or in vivo, that indeed the muscarinic antagonist could enhance myelin formation and repair in vivo. So this is one compound, one family of compounds, one chemical class that might be of interest for repair studies in MS. However, this is a very elegant study, but this is not the only study. And I have tried to put together all the candidates that are new, that have been shown to enhance myelin repair. And have to apologize, even if this table is quite busy, it's not complete at all. There is many other, and I've, of course, to apologize for this. But you can see here, you have several interesting family of compounds. The retinoic acid agonist, and in fact, this has been identified by Robin Franklin in Cambridge. It was probably one of the first one to identify a compound that showed both in vitro and in vivo. And you can see that all these compounds have shown activity in vitro and in vivo. So they might be relevant for therapeutical trials. We have worked on sigma agonists and showed also they could really enhance myelin. There are notch inhibitors, sphingosine 1-phosphate, a neuropoietic cytokine. It was from our lab also. LINGO-1 antagonist, you have heard about this. Muscarinic and so on. You can see opioid, leukotriene, purinergic, many steroids, antipsychotic, hormones, antioxidants. So the list is very long, finally. We have more than 50 compounds or 50 family of compounds that could be of interest for repair trials. So we have not nothing. We have many things to test now from the pharmacological point of view. And we are at this time where we have shown that this is a relevant mechanism, and we have many candidate drugs that we have to test in practice. It's not only a matter of drug. Probably some other alternative strategy could be useful to promote repair. And we and others have shown that enhancing the electrical activity of neurons could also enhance mind formation and probably repair. And there have been recently, we have shown this a long time ago, but recently many works has confirmed this hypothesis, suggesting that therapies based also on electrical stimulation or exercise could also be of interest for promoting repair. So many possibilities. So how now to design a study to select among these possibilities? We have not only one candidate that we want to push to a phase 3. Now we have to choose what would be the best strategy for the future. And for this, we need innovative, sensitive phase 2 trial design. So several have been proposed. I will illustrate two of them. One will propose to use the optic nerve system as an integrated system, and the second one will be a more global approach using imaging outcomes. Why using the optic pathway? Because it's a very well-known integrated pathway, and electrophysiological measures can reflect by the visual evoked potential latency, probably the myelination level, and by their magnitude of the potential, also the axonal degeneration. So it's very simple to understand, and therefore it might be of great interest for measuring some effect on repair. However, we have to know, and this is from the study of Fischer that studied the remyelination in all the region of the brain of a large cohort of patients, and the shadow plaques are shown here in pink, and you can see that those shadow plaques are quite a large number in supratentorial area, less numerous in infratentorial area, but very few in the optic nerve. So probably it's not the most sensitive region of the brain to investigate repair. It's a good region, but probably not the most sensitive, and it may happen that we miss some effect of a drug if we only focus on the optic nerve. But however, the clemastine trial that Armand mentioned in the previous talk has been done using this paradigm. And you can see here, this is a crossover study. This is the placebo arm, and this is the treated arm. And you can see that there is a difference which reaches significance at the end of the first period, 3 months, with a slight improvement of the visual evoked potential latency with clemastine compared to placebo. And by crossing the arms, you can see that there is an inversion of the tendency during the second period. So there is something here in the optic nerve that may suggest that clemastine and muscarinic antagonists could have some effect on repair in this system. We now need more advanced study. So a second way to investigate repair would be to consider the whole brain. It would be better to consider the whole CNS, including the spinal cord, but it's very tricky now to develop sensitive measures specific for myelin in the spinal cord. But in the brain, I've showed you that PET could bring some added value, and some advanced MRI, I will not detail this, could also be of great interest. So by combining those techniques, we might be able to pick up some repair in a more sensitive way. However, as I showed that the endogenous remyelination profile could be very heterogeneous depending on the subject, we could suggest that this could be really important to analyze also in the study design. This would imply to make first a running period, which would allow to determine what is the spontaneous remyelination profiles of patients, and therefore to compare a given treatment with a placebo to make a more classical comparative study. And at the end, in the model, we could also include this variable of individual potential repair to really extract the pharmacological action on repair and not only variation between patients. We have made some estimation, sample size evaluation based on the PET result we obtained, and we estimated that 32 patients per group would allow to detect a 20% increase in PET-derived remyelination, and which is quite feasible in terms of early phase 2 trial to discriminate between drugs or between different dosage of a drug. So I will now close this first part of mining and move to the second part, which is probably linked, which is the persistent neuroinflammation. So what do we know about this neuroinflammation? First, I will not discuss a lot here about adaptive immune system, lymphocytes, and so on, which are targeted by current available therapy, but mostly about the innate immune system, which include phagocytic cells, either macrophages or microglia. We know since a long time that those axonal transections, which are seen in lesions, are strongly correlated with the level of inflammation in lesion, and this is probably really linked to innate immune cells. It has also been shown by Don Mahad that the energy deficit in neurons, especially in axons that are degenerating, is linked to a mitochondrial deficit, and that this mitochondrial deficit is correlated with the number of HLA-positive cells, so cells belonging to the innate immune system. So from pathology, we know that this innate immune system could play some role in axonal degeneration. You can see for this very interesting review by Kutzelning and Lassman, and they are described in the brain of patients, especially at different stages of the disease, the involvement of this innate immune system. And you can see here in a more acute active brain, depending on the stage of lesion, the activation first of macroglial cells, you can see here, and therefore of macrophages, and therefore when the lesion becomes inactive, you have nothing or very few inflammation. And very interestingly also, those chronic active lesions has been described in the brain of MS patient, and they are mostly consisting in an activation of macroglial cells. So both at acute and chronic stage, those lesions are involving innate immune cells, mostly macrophages at the acute stage, and therefore microglial cells at the more chronic stage. And they are characterized here. You can see the smoldering plaques, which are quite well defined with a rim of innate immune cell activation. And it has been shown that those smoldering plaques that you can see here in orange are really characteristic of progressive phases of the disease, at least in post-mortem study. As you can see here, in relapsing patients, they were not found, but in secondary progressive, either with or not gadolinium enhanced, active lesion, acute active lesion, and primary progressive, you have some lesion. And you have also persisting chronic active lesion at this late stage of the disease. They are more numerous, more in a larger number at the relapsing stage, but they persist in secondary progressive stage. So both in normal appearing tissue and in lesion, you can have an acute or chronic activation of this innate immune system in pathological brain. So what can we know about their involvement in vivo in patients? For this, we have no MRI metrics that is specific for these immune cells. So we also can use PET and selective tracers that can bind to innate immune cell. The most popular target to image this is the TSPO, which is expressed mainly in activated macrophages and microglial cells in the brain. This is not fully specific, as it is also expressed by some endothelial cells and astrocytes. But you have a major component that is linked to the activated innate immune system. And there are several compounds that can be used for this PET study. The reference compound was the PK11195, and there has been several studies showing an increased uptake of this compound at different stages of the disease. And we recently applied a more recent second-generation tracer that is fluorinated, allowing more dissemination of its use. We developed a non-invasive quantification method and investigate this in a population of patients by applying an innovative processing method that generates individual regional maps of innate immune cell activation. I will not insist too much on the methodology, but you can see the result we obtain with such a method. You have 3 examples of patients with a secondary progressive MS. And you can see in yellow the voxels that are classified as with significant inflammation in the normal appearing tissue, and in red, those with activation in the lesion, in dark red in perilesional area, and in light red within the lesion. And you can see that the 3 profiles are very different. This one with very minor activation, whereas at the opposite spectrum, you have this kind of activation profile, which is very huge, either in the normal appearing tissue and in lesion and perilesional area. So we therefore analyzed each single lesion of each brain of those patients, and we were interested to find several patterns. You can see this pattern of lesion with a strong activation inside the lesion and around the lesion, and also those lesions with no activation. And in between, you have several patterns, with this one also that could remind the smoldering plaques with nothing inside and a rim of activation around the lesion. So we classify each of the lesions of this brain patient, of the brain of this patient. There were 35 patients with all stages of the disease, either as active lesion, if they had more than 50% of the voxels that were activated, or as inactive lesion with less than 10%. So this is a very contrasted classification, very conservative one. And what we were surprised to find is that there was a high proportion of lesions that were classified as active at all stages of the disease, relapsing, secondary progressive, primary progressive. There were between 25 and 35% of the lesions that were classified as this. And what was really interesting was that these lesions were not enhanced at all by gadolinium. So they were considered on classical MRI as totally stable. So we identify, using this technique, novel lesions that are active and not recent, so probably subacute or chronic active lesions. So the next step was to analyze the clinical relevance of this finding. And interestingly, when we looked at disability trajectories of patients measuring the EDSS progression during the 2 years preceding the study entrance, we found that the 2 key parameters that were explaining this disability worsening were the number of active lesions classified on PET scan and the proportion of voxel activated in the perilesional area. So these were the 2 interesting parameters that were explaining the disability worsening of patients. And this attests here again that this kind of activation of innate immune cell could have some clinical relevance, even in vivo in patients. And therefore, this is a key step before developing a new therapeutical trial in this field, of course. So now moving to the 3rd step here again, to discover or to generate a therapeutic agent. The field of macrophages, microglial cell is a quite complex one in terms of biology. I'm not an expert on this, so I will not cover all, but here again we have a range of candidate therapies that can be applied to try to influence, to impact this innate immune cell activation. You can see some are more specific to MS, so some are already known, fingolimod, interferon, etc., but also cyclin and also interleukins 10, 33, and there are many more, and from other diseases you have also other possibilities. So the problem is that we have a range of candidates here again, and we need some phase 2 trial designed to be sufficiently sensitive to a signal that will push to develop one over the other drug. So if we think about PET Probably we will have other imaging method, but we also have made sample size estimation if we use the method I just presented before, and we would need about 60 patients per group to detect a 30% decrease in the extent of activated voxel in the total white matter, which is a little bit more than what I've shown for myelin, but which is feasible in terms of the phase 2 trial to select among candidates. So I could close now, but I would like to make what I will say an epilogue, because probably what I've shown to you is very simplistic. And considering to target a simple cell population is probably not realistic, but very simplistic. Why? Because we now know that each of these cell populations, meaning either macroglial cells or the oligodendrocytes or the astrocytes and so on, shows a great heterogeneity. And this has been shown by many studies using single-cell profiling with RNA-seq and so on. And we know that there are several populations of oligodendrocytes in our brain, several populations of macroglial cells, depending on aging, depending on the phase of the disease, depending on the localization of the brain and so on. So they are very heterogeneous, and considering only one population is a little bit too simplistic. But I will not cover this. It's a very complex and evolving field. The second one is that none of these cells act in a solitary way, and they are very strongly interacting together, of course. And we just attempt to make an illustration about this. It has been shown that this innate immune cell component was not independent of the remyelination process. And finally, it's now well described that depending on the polarization state of those innate immune cells, they were called before either M1 when they are pro-inflammatory or M2 when they are more regulatory or protective. This classification is still evolving, so it's not perfect, but using this very simple classification, it has been shown that the M1 was probably inhibiting myelin repair by acting on the differentiation of oligodendrocyte, whether the M2 population was promoting myelin repair. So acting directly on innate immune cell could influence the remyelination process itself. And along with this result, it has appeared that some drug, here again, can now emerge that are acting on the innate immune cell population and that have been shown either in vitro or in vivo in models that it could also enhance myelin repair. And you can see some example here. We find again the retinoic acid agonist, the sphingosine 1-phosphate, but also oleoxime, the pioglitazone, also sildenafil, and so on. So some very funny repurposed drug could be of advantages also for repairing myelin. So here again, we have new possibility to develop clinical studies. And finally, even beyond this innate immune cell, it has been shown that this process of repair and of chronic innate immune activation was not independent of the adaptive immune system itself. I will just, to finish, quote this very interesting work that has been performed by Violeta Zujovic in our institute. It has been published in Brain last year. What she has done is to take the lymphocyte, T lymphocyte, of patients with MS. And she has grafted this T lymphocyte in a demyelinating model of mouse induced by lysolecithin in the spinal cord. And she investigated the impact, the influence of those lymphocytes of MS patients on the repair process itself. And what she found was, depending on the subject, some subjects were inhibiting by their lymphocyte in the lesion the process of repair, whereas some others were permissive to repair. You have here the control subject, here the two groups of MS patients, the one classified as low as they inhibit the remyelination process, and the one classified as high as they promote the repair process. So the lymphocytes themselves could impact this remyelination process when they are inside the lesion. And she further showed that this effect was mediated by signal through the innate immune system. So the lymphocytes, the T lymphocytes, are signaling to the microglial cell to become either M1 or predominantly M1 or predominantly M2, and therefore they can enhance or inhibit the repair process. And she has identified some K molecules that could be involved in this crosstalk. This molecule would be inhibitory for repair, and this molecule would be promoting the repair phenomenon. So it's a global phenomenon, an interrelation between all inflammatory mechanisms and the repair process that finally result in the success or failure of remyelination. And considering only the oligodendrocyte cells in terms of pharmacological study would probably be a mistake. We should investigate before going through a therapeutical trial, whether a pharmacological compound that may enhance myelin repair in a model could also enhance myelin repair in an environment that could mimic MS. So this result has been added to others, showing that either a Th17 cell could impair repair and regulatory T cell could also promote myelin regeneration. So it's not an emerging field that showed that not only the repair is probably an endogenous process in the brain, but this is in close interaction with the immune system, and therefore myelin repair quantification would become an outcome of interest also for drug acting on the adaptive immune system. So finally, the graph I've shown to you was, of course, very simplistic. And this one is also simplist, but we can see here that remyelination failure and neuroinflammation are closely interlinked, and that the adaptive immune system is also really in dialogue with all those mechanisms that may result in energy dysregulation and neurodegeneration. But finally, we have also shown that remyelination and neuroinflammation are indeed key mechanisms that are relevant in animal models, human pathology, and in vivo in MS patients, that we have a large number of candidate therapeutic agents that could act on this mechanism and that are really ready for therapeutical trials. There are several proposals for the design of those trials, but this is still a matter of debate, and this is really a burning question. And finally, immune cells are really relevant targets also to promote repair. So to conclude, regenerative trials are probably one of the new innovative areas in the MS field. And I will finish by showing our team in the ICM in Paris-Salpêtrière. And this is brainstorming that we have done in Restaurant Les Papilles, which is the same that you showed this morning in Paris. And this is where we discuss, of course, about remyelination, but also of other topics, such as resveratrol, which is in the red wine, and also promote repair. Thank you very much.